Good afternoon. Welcome to Grand Rounds today. Before we get started, I just wanted to take a minute to express appreciation to Avela Bank, who have been generous sponsors and supporters of the CME programming here at Mary Greeley, and also to introduce Kevin Geis, who is the Eastern Region Manager and President of the Ames branch, who has a few introductory remarks, and please join me in welcoming Kevin.
Thank you. Well, it's our honor to be here again today. It's especially Avela Bank's honor to be a sponsor of the Grand Rounds. We've been doing that for a number of years. We find great value in what this organization does for our community. You're a vital group of our community, and so we appreciate just a chance to be able to support it and provide good educational information out to a wide group of participants. I'm particularly interested in the day because I've had a close acquaintance that has had 2 carpal tunnel surgeries here at Mary Greeley, and they've been very, very successful. So I'm excited to hear a little bit more about that, and personally thank the physicians here that took care of that person and made those surgeries successful. So we're honored to be a sponsor and look forward to hearing the presentation.
So actually, I'm reintroducing Dr. Betsey Bean. Dr. Bean is an orthopedic hand surgeon. She did her orthopedic residency at Madigan Army Hospital and then did her hand fellowship at WellSpan York in York, Pennsylvania. And she's been on the medical staff here since August 2021. And she kindly has accepted our invitation to provide us with a review of carpal tunnel and operative management. Please join me in welcoming Dr. Betsey Bean.
Thanks. All right. I'm on? Good. I feel like a Peloton instructor. It's like dream come true. Okay, well, thanks for the opportunity to present. About 1.5 years ago, I gave a Grand Rounds talk on upper extremity compression neuropathies. So we spent a fair amount of time talking about carpal tunnel syndrome, but didn't go into the surgical treatment options all that in depth. So they have asked me to talk more about endoscopic carpal tunnel release in particular. So we'll start with just a review of the basics, and then we'll delve more deeper into surgical treatment options, the differences between endoscopic and open carpal tunnel release, and why you might choose one technique over the other. Hopefully by the end of this talk, everyone will feel comfortable diagnosing carpal tunnel syndrome. We'll know when surgery is indicated, and then also know some of the differences between endoscopic and open carpal tunnel release. So the carpal tunnel syndrome is very common. It's the most common upper extremity compression neuropathy. Somewhere between 0.1 to 10% of the working population in the United States is affected by carpal tunnel syndrome, and 5% of the general population is affected. So it's very, very common. We see it more commonly in women, and especially pregnant and nursing women. But it has a bimodal age group distribution. So we see it peak in the 50s and then a second peak in the 8th decade of life. So it's very common, but another reason to care about it is because we spend a lot of money treating carpal tunnel syndrome in the United States. We spend about $2 billion annually in treatment for it, and there are over 500,000 carpal tunnel release surgeries performed every year in the United States alone. The carpal tunnel is an actual tunnel. It's formed by the carpal bones on the back, and then radially and ulnarly, it's also bordered by the carpal bones. The transverse carpal ligament forms the roof of the carpal tunnel in the volar aspect of the wrist. In the tunnel, you have the median nerve along with 9 flexor tendons. The median nerve itself is the most superficial structure in the tunnel, so it lives just deep to the palmaris longus, which you can see in most patients if they have it as the central wrist flexor tendon. The median nerve has a branch that it sends to the thenar muscles. So that's called the recurrent motor branch or the thenar motor branch. It usually divides distal to the transverse carpal ligament and then it travels retrograde to the thenar musculature to innervate those muscles. And the remaining branches of the median nerve will divide once it gets past the transverse carpal ligament, and then innervate the lumbrical muscles to the index finger and middle finger, and then also do sensory innervation to the radial 3.5 digits. This diagram on the left highlights the sensory innervation of the median nerve. So the blue part is innervated by the palmar cutaneous branch. So think of the palm primarily. That is a branch of the median nerve, but that nerve doesn't travel through the carpal tunnel. It divides prior to it. So the green area is innervated by the median nerve, and that sensory innervation will extend dorsally to about the PIP joints. Some patients can clearly define where their numbness is at, but a lot of patients can't. I think it's kind of hard for our brains to compute what's numb and tingly, especially if symptoms are primarily in the middle of the night, but most patients can recognize that their small finger isn't all that numb. Most patients want to know, why did I get this? Why did this happen? And we know that there are several risk factors to developing carpal tunnel syndrome. There's strong evidence that patients with a higher BMI have a greater risk of developing carpal tunnel syndrome. Also, patients that do repetitive hand and wrist motion activities. So similarly, there's moderate evidence that people that do assembly line work, that are doing those repetitive hand and wrist activities, are at higher risk. Or people that do a lot of computer work, or even gardening, that can be a contributor to this. Patients that have rheumatoid arthritis also are more likely to develop carpal tunnel syndrome, usually because of other things that are associated with that make less space in the tunnel, like tenosynovitis or wrist arthritis. And then there are other rare causes. So anything in the carpal tunnel that is a space-occupying lesion, like a ganglion cyst or tenosynovitis. You can have vascular tumors or rheumatoid nodules, or even tumors within the median nerve, like a schwannoma or a neurofibroma. Sometimes aberrant anatomy, like muscle bellies that are too proximal or too distal, can decrease the space in the tunnel. Those causes are less likely, but occasionally we'll see that. And then there are other physiologic conditions that increase risk. Things like diabetes, alcoholism, inflammatory causes, typically because they're causing tenosynovitis. And then fluid balance alterations, so like hemodialysis, and then pregnancy can contribute to that. Patients with carpal tunnel syndrome present primarily with numbness and tingling, but they can also have pain in the median nerve distribution. And that should be in the fingers, not so much in the palm, because of that palmar cutaneous branch that we talked about earlier. It doesn't run in the carpal tunnel. And nocturnal symptoms are really the hallmark of carpal tunnel syndrome. So usually patients will describe it mostly at night, may awake them from sleep, or first thing in the morning that they feel it the most. We think this is because of wrist position when sleeping, so more wrist flexion can contribute to that. But it may also be due to some fluid shifts and fluid imbalance or balance changes that happen when we're lying horizontal. And then daytime symptoms can also occur, usually activities that are requiring repetitive gripping or wrist flexion or extension for a long time. So driving, holding a steering wheel, riding a bicycle, even holding your phone or reading a book. That position that you're holding that object can aggravate the nerve. Anything where you're doing wrist flexion or extension decreases the space in the carpal tunnel, so that's why the nerve is pinched. And then in severe disease, we'll see intermittent numbness become constant. And then they also will have a lot of times thenar weakness and sometimes thenar atrophy that you can visibly see. They'll complain that they drop things, and they'll also complain that they can't feel things, like picking up a coin off the floor is really difficult because they simply can't feel it, or buttoning buttons is pretty challenging as well. On physical exam, sensibility testing is a really important part. Two-point discrimination is a relatively easy test that is a good way to determine where patients are numb and how bad it is. So two-point discrimination is normal when it's below less than 6 millimeters. Anything greater than that is abnormal. Strength testing primarily evaluates the abductor pollicis brevis, which will palmarly abduct the thumb. So patients that have more severe disease will have significant weakness, or you can sometimes see thenar atrophy. And it's always important to compare it to the other hand, because sometimes it's mild, it's kind of subtle, but you can pick it up when they have a normal contralateral side. And then provocative tests will place more stress on an already compromised nerve, and they should exacerbate numbness, tingling, and sometimes pain. So Tinel's, which is percussion over the median nerve, should send numbness and tingling distal into the hand. Proximal numbness and tingling with Tinel's is not a positive test. And then Phalen's, or holding the wrist in flexion for a period of time, should reproduce numbness. Durkin's is just when you apply pressure over the carpal tunnel. And you can combine Durkin's and Phalen's, and that's the most sensitive and specific test. But whatever you do, it's important to do multiple of those provocative tests. That's actually one of the clinical practice guidelines, is that you shouldn't rely on one single test, because that's likely to give you a false positive or false negative. So do multiple to help make the diagnosis. The CTS-6 score is a validated diagnostic tool that can be very helpful to help make the diagnosis, and also helps you figure out whether you need to get electrodiagnostic studies. So this is based on 6 clinical components that have different point values. 2 of these are subjective criteria, and the other 4 are objective based on your physical exam. So these will include numbness, that's primarily in the median nerve distribution, nocturnal symptoms that will awake patients from sleep, and then the objective criteria are weakness or atrophy in the thenar muscles, a positive Phalen's test, positive Tinel's test, and loss of two-point discrimination. And they're not on here, but each has a specific value, and then you add them all together. If you have a point score greater than 12, you have a very high probability of having carpal tunnel syndrome, and a point value of 5 or less is much lower. So if you're in one of those, high or low, you probably don't need electrodiagnostic studies, because they're probably not going to change your diagnosis or what you do. Whereas the patients that are somewhere in the middle, the nerve testing can be very helpful for diagnosis. On the right side here, we have the cat's hand diagram. This was developed in 1989, and this is for patients to fill out and say, this is predominantly where my symptoms are at. That's also a validated diagnostic tool that's been shown to be very useful. You can use that and compare it to what they found in their study to show what's consistent with carpal tunnel syndrome and what's not. Non-operative treatment is appropriate for patients that have mild to moderate symptoms. So those are patients that have intermittent numbness, no thenar atrophy, or no thumb abduction weakness, or if they have electrodiagnostic studies, if they do not meet severe criteria and there's no evidence of denervation. The proven effective conservative management options are a nighttime wrist splint. This should hold the wrist in a neutral position. The type of brace is important. Some patients will come in and see me and they'll have like copper fit gloves or a neoprene wrap. And although those are reasonable, especially with daytime use, that's not the wrist brace that they should be sleeping in. They need something that has a rigid insert that will hold the wrist in a neutral position. Daytime use of a wrist splint isn't necessary. That's at least not been what's studied. I think some patients may report some symptom improvement, but what really matters is sleeping in the brace and doing so consistently. A steroid injection into the carpal tunnel should also improve symptoms. They've done studies to evaluate how much relief patients get from either a brace or a steroid injection. And it seems like if you follow them out for a year, that most patients will have recurrence of their symptoms. But sometimes you can get up to a year of relief with a steroid injection. It's important to know that patients with diabetes will often not have as long of relief. Their symptoms are more likely to recur faster, especially with a steroid injection. And then there is some evidence that oral steroids are helpful, but it's definitely not as strong as the evidence for a nocturnal wrist splint and steroid injection into the carpal tunnel. And then when is surgery indicated? Well, the main indications are that if they have severe carpal tunnel syndrome or they present with severe carpal tunnel syndrome. So if patients have constant numbness in the median nerve distribution, if they have thenar atrophy or thumb abduction weakness, and if they have electrodiagnostic studies that show severe changes or axonal loss or denervation. Then the other indication is just failure of conservative management, which I say is somewhere between 4 and 6 weeks of consistently using a wrist brace, or you've done a steroid injection, it worked temporarily, and you want more definitive treatment. It's also important to know what's not effective so we don't waste time and money. And there's strong evidence that magnet therapy is not effective. There's also moderate evidence that anti-inflammatory medications and medications like gabapentin are not effective either. So the best primary treatment is a nocturnal wrist splint for a good 4 to 6 weeks. And if that fails, then consideration of a steroid injection or maybe surgery, depending on how bad symptoms are. So what is carpal tunnel surgery? It's simply to open the carpal tunnel, to take the pressure off of the median nerve. And to do that, we divide the transverse carpal ligament, which forms the roof of the carpal tunnel. Now, historically, it may have included other procedures like internal neurolysis, like freeing up the nerve from any surrounding scar or tenosynovitis, steroid infiltration into the carpal tunnel, placement of a drain, maybe flexor canal debridement. That's what a lot of patients say. Well, they did my carpal tunnel release and cleaned up the tunnel. They did a survey back in 1987 of all of the ASSH members, or American Society of Surgery for the Hand, which are fellowship-trained hand surgeons. And they asked, what's your standard treatment for carpal tunnel syndrome? And they found that the majority of surgeons were doing one of these things. So dividing the ligament plus something else. And then they repeated that survey in 2012, and they found just the opposite, that the majority of surgeons are no longer doing anything else besides just opening the carpal tunnel, dividing the ligament. So to accomplish that primary goal, and I should say, and outcomes are the same. It still works well. Patients have relief of numbness and tingling. So it tells us, in most cases, you don't have to do anything besides just cut the ligament and open the tunnel. So to accomplish that, you really just need to see the transverse carpal ligament well and make sure that all the important stuff in the tunnel, the tendons, and primarily the median nerve is out of the way, so that's safe. And you can achieve that goal through an open procedure, a mini open procedure, or endoscopic techniques, either through one portal or two portals. And the new sort of faddish way currently is ultrasound guided through a really small incision. Nowadays, most surgeons will do an open carpal tunnel release through still a pretty small incision, 4 centimeters or less. And this is the gold standard that we have good outcomes and low complication rates. Endoscopic carpal tunnel release was developed to accomplish that same goal just through smaller incisions and utilization of a camera to visualize the ligament. And it has the advantage of preserving the palmar fascia and layers of the palmaris brevis muscle, which you typically have to dissect through to get down to the ligament if you do it through an open approach. So by preserving those layers, it may add a protective layer to the nerve afterwards and also allow for faster recovery because there's less soft tissue disruption. Endoscopic release has become much more popular recently. One of those surveys I talked about in 2012 they asked members of the Hand Society, what are you primarily doing surgically for carpal tunnel syndrome? And in one study, 26%, and another survey, 36% said that they primarily used endoscopic carpal tunnel release, which is much more than in previous years. That one study was 2012, so we're 10 years past that now. Interestingly, about 50% of the respondents said they never did endoscopic carpal tunnel release, and then the other 15 to 25% said they used both options. There are contraindications to an endoscopic technique, and those include poor wrist extension. So if you can't extend the wrist well, you can't do it safely, and we'll talk about that in the upcoming slide when we talk about technique. And then a space-occupying lesion that's contributing to carpal tunnel is also a contraindication. It's hard to know if patients have that ahead of time. Usually you don't unless you have some suspicion and you get an MRI or an ultrasound that would show you that. But if you know that it's there, then you should do an open approach, which allows you to see better, have more space to remove it. Also, if patients have history of trauma or some congenital abnormality that alters anatomy, you should think twice about doing it, doing an endoscopic technique. And then revision carpal tunnel, most surgeons will do an open approach for that, although that's a little bit debatable. Endoscopic carpal tunnel release has been around for over 35 years. It was first described in 1987 by Okutsu. There have been many modifications to the technique since then. There are two main ways to do an endoscopic carpal tunnel release, and they differ primarily whether you use one or two portals. The two-portal technique was developed in 1989 by Chow. The first portal is placed just proximal to the wrist flexion crease and just ulnar to the palmaris longus. And you divide the wrist fascia, and then the synovium that's on the undersurface of the transverse carpal ligament is scraped away, so you can clearly see the transverse fibers of the ligament. You insert a cannula through that proximal incision into the carpal tunnel, and then you really have to hyperextend the wrist so that you can pass that cannula past the distal edge of the ligament. And then you can feel the tip of the trocar in the palm and make a small incision over that in order to pass the cannula all the way through from proximal to distal. And once you have your cannula established, then you place your camera on one end and then your special blade on the other end. You can see the ligament and then divide it through that. So the picture in the center bottom is a two-portal technique that you see there with the cannula in the carpal tunnel. The second option is a single portal technique. This was described by Agee in 1992. And it starts the same way. So you make an incision just proximal to the wrist flexion crease, and you elevate the antebrachial fascia, and then you scrape the synovium from the undersurface of the ligament. And then you need a blade assembly device, and this is proprietary to whatever system you're using, but it combines your camera and your knife blade, and usually the cannula and the blade are disposable. So that you insert your blade assembly device into the carpal tunnel, and once you can clearly see your transverse carpal ligament, then you can deploy the blade, which is at the end of the cannula in front of your camera, and then you pull back and you can cut the ligament retrograde. This picture on the left here is a single portal approach, and you still need to be able to extend the wrist in order to get the correct trajectory to cut the ligament, but it's not quite as important to hyperextend compared to the two-portal technique. And if you look at the picture on the top right, what you're seeing is your view through the cannula in either approach, and you can see the transverse nature of those fibers. That's the transverse carpal ligament. And then the picture below it is the two leaflets of the transverse carpal ligament once you've divided it. I think this is actually from a case that I did. So that's exactly what you see every time. And if you look above the two leaflets in that bottom right picture, It's just palmar fascia and maybe some fibers of palmaris brevis muscle. And then down below is the contents, or are the contents of the carpal tunnel. So you really can't see much. It's important to know what you don't see, and that's really everything in the tunnel. So if there's anything abnormal that you're looking for, if you have to do any other procedures, like get a biopsy of the tenosynovium or do some sort of debridement, you really can't do it through this approach because you can't see well and you don't have you don't have incisions that are big enough to really do anything safely. In contrast, open carpal tunnel release is performed with a longitudinal incision at the base of the palm. And through this incision, you can see the transverse carpal ligament and incise it longitudinally. And you can also inspect the contents of the carpal tunnel. You can do a tenosynovectomy if you need to, or remove a mass if you need to. And it's still a relatively small incision, but in order to get down to the ligament, you have to incise everything in its path, and that's palmar fascia and usually some palmaris brevis muscle. So then the question is there a benefit to endoscopic carpal tunnel release, and is it safe? And there are a lot of ways to evaluate and answer those questions, and many studies have tried to do that. So the first question is, does one technique offer better symptom relief? The Boston Carpal Tunnel Syndrome Questionnaire is a validated patient-reported survey, and it evaluates symptom severity and functional status. There was a meta-analysis of 7 studies that used this questionnaire, and at 1 year after surgery, they found no difference between endoscopic and open carpal tunnel release in terms of symptom relief from that survey. Additionally, if they utilized the visual analog scale to evaluate pain, they found that there was no difference before or after 3 months postoperatively. They also looked at sensation with Sims-Weinstein or 2-point discrimination, and they found that that was no different at 3 months or at 1 year. They did find a difference in improvement in sleep, and that's mostly the first 6 weeks or so after surgery. The patients that had endoscopic carpal tunnel release had better sleep quality compared to open. But at their final follow-up, somewhere between 6 and 12 months after surgery, there was no difference found in sleep. Related to symptom relief, there's a concern, and it's considered a complication with endoscopic techniques, that you may not completely divide the ligament, and that's because it's hard to see. I think especially with a one incision technique or one portal technique. So the question is that a potential complication that we're setting patients up for if we incompletely divide that ligament? And that's a little bit hard to answer, except if you consider relief of symptoms, because you'd expect symptoms to persist if the ligament was incompletely divided. And based on these studies showing no difference in symptoms, I think we can conclude that incomplete release of the ligament is either not clinically significant or it doesn't happen. A few studies have evaluated pinch strength, grip strength, and hand dexterity and compared the two techniques. And they have found that there are significant differences in the first 3 months after surgery that favor endoscopic release. But after 3 months from surgery, there's really no difference between the two techniques. And that initial strength benefit is probably because you're preserving those structures that are superficial to the ligament, like the palmar fascia and the muscle, and leads to faster healing, less soft tissue disruption. Return to work. Studies do show that patients are able to return to work faster with endoscopic surgery. And one meta-analysis reviewed 11 studies. They showed an average return to work of about 8.73 days faster. Another with endoscopic. Another study showed, other studies have shown anywhere from about 7.2 days to 9.5 days faster. But these studies are hard to interpret because they're pooled analyses, so they don't differentiate laborers versus patients that have desk jobs. So we're grouping them all together, getting an average. It does show endoscopic techniques to allow patients to go back to work faster, but it's a little hard to counsel patients because you have to know what they do for work to give them an appropriate return to work timeline. But I think for laborers, most surgeons would say probably somewhere between 4 and 6 weeks after surgery. This return to work faster is probably one of the strongest arguments for endoscopic technique in my opinion, because that has certainly borne out to be true in all of the studies. What about patient satisfaction? There was one randomized controlled trial that was published in 2020, and they evaluated patients that had bilateral carpal tunnel syndrome that were undergoing surgery for both. On one side, they did an open carpal tunnel release, and then on the other side, they did an endoscopic release, and they spaced the surgeries about 4 weeks apart. And it was a small study. It only included 30 patients, so you have to interpret it with caution. But in all of their outcome measures, including pain scores, sensation, thenar strength testing, grip strength, the carpal tunnel functional status score, symptom severity score, they found no difference. But 24 out of 30 patients said that they preferred an endoscopic technique, and then most of them cited less pain as their primary reason. So the majority preferred an endoscopic technique, but small differences that probably were important to them compared to open. Not enough of a difference to capture based on those scores. Similarly, in a meta-analysis of randomized controlled trials, they also found that patients tended to be more satisfied with an endoscopic technique, but there's no validated tools that measure patient satisfaction. It's typically done with either just a point scale or an either-or question, and so it makes it very subjective. It's not a scientific measure, but it doesn't necessarily make it a less important question. It's also very important to evaluate potential complications between the two techniques. Complications are difficult to study because, for the most part, they're pretty rare, and they depend heavily on surgeon reporting. So theoretically, there are many possible complications with either technique, and probably more potential catastrophic complications with endoscopic techniques, given the anatomy and sometimes difficulty with visualization. And the major concerns are about injury to surrounding neurovascular structures like the median nerve itself or branches of the median nerve. The ulnar nerve and artery are just ulnar to the carpal tunnel, not in the tunnel, but close enough. If you're out of plane, they're certainly at risk of injury. And then just distal to the transverse carpal ligament, you have the superficial palmar arch, which is certainly at risk if patients don't have good wrist extension, or you're just off just a little bit with your placement of your knife blade. Early studies of endoscopic carpal tunnel release reported a very high complication rate. However, as surgeon experience and tools have improved, more recent studies have shown similar complication rates. Some studies even show higher complication rates with open carpal tunnel release. One meta-analysis published in 2015 was done specifically to evaluate safety and complication risk of endoscopic techniques. They included 27 randomized controlled trials, and the endoscopic technique varied pretty evenly between 1 and 2 portal techniques. And they found that there was no difference in major complication risk, but they did find significantly higher risk of wound and scar complications with an open carpal tunnel release. And they found a higher risk of transient neuropraxia in endoscopic carpal tunnel release. Transient neuropraxia is temporary paresthesias, sometimes temporary weakness that occurs after endoscopic technique typically. And we think that it's more common with endoscopic because you insert the cannula into the carpal tunnel, and when that's in the tunnel prior to division of the ligament, you significantly increase the pressure in the tunnel. So They've tried to measure it. It is quite significant. It's brief, but that alone may be enough to cause some transient neuropraxia. That always, by definition, that resolves on its own, but can take some time afterwards. Another complication concern with endoscopic technique is potential injury to the thenar or recurrent motor branch. And this branch it comes from the median nerve. In most patients, it will divide just distal to the transverse carpal ligament, and then it will travel retrograde back to the thenar muscles and innervate the majority of the thenar muscles. But in some patients, they have some variation in anatomy. And so instead of dividing past the ligament and traveling around it, it will divide inside the carpal tunnel and then travel through the ligament over to the thenar muscle. There are other variations, but this is the primary one that people have concerns about with endoscopic techniques. And early on, somebody figured out that you're more likely to see some hypertrophic muscle that is over the transverse carpal ligament if patients have a transligamentous thenar motor branch. And so they studied it to try to figure out how common that is, and if maybe that's a good clue to look for to make you aware and extra cautious in your surgical approach. And so one person studied 100 consecutive patients going through open carpal tunnel release, and they did a bigger incision in order to evaluate the anatomy. And they found that a transligamentous motor branch occurred in 23% of those patients that have hypertrophic muscle over the transverse carpal ligament. And in only 2% of patients that had a transligamentous motor branch, they didn't have muscle. So what that told us is if you see hypertrophic muscle over the ligament, you're at higher risk of having a nerve branch that's going to travel through the ligament, and so you need to be careful and make sure you protect that when you're doing surgery. But the problem is you can't see that muscle from inside the carpal tunnel. So you lose the hint that might be present, and so it's at theoretically a little bit higher risk of injury with an endoscopic approach. Another group did a study on almost 900 primary carpal tunnel releases in about 800 patients. This was an academic practice. They had 11 fellowship-trained hand surgeons, and they asked surgeons just to report how often you see a transligamentous motor nerve. And they only found four hands out of almost 900 hands that had a transligamentous nerve. And they were done, these carpal tunnel releases were done through an open approach, a mini open approach, an endoscopic technique, really just surgeon's preference. So there may have been some that were missed, potentially, but there were no injuries to the nerve. So despite it being a theoretical concern, it seems to be very rare, but something to be cautious of either way. The recommendation is that whenever you're cutting the ligament, you do it on the most ulnar aspect because all of the important structures that are exiting the carpal tunnel will move radially. So if you're on the ulnar aspect, everything should be safe, including a transligamentous motor nerve. What about cost? There's different ways to evaluate it as it relates to carpal tunnel surgery. Direct costs are significantly higher with an endoscopic technique. This is mostly related to the disposable items like the knife blade and the cannula, and there may be startup costs as well with those systems. There usually are. Those are things like the dilators and the synovial scrapers, as well as your blade assembly device if you use a one incision approach. So those things all cost money versus an open carpal tunnel release, which you just need your basic operative set for. You don't need anything fancy. But direct costs are also related to the surgical setting and anesthesia as well. So the operating room is more expensive than an office procedure room. And having an anesthesiologist provide sedation or a regional nerve block is more expensive than just local anesthesia in the office. So there's different ways to assess direct upfront costs, but it's certainly more expensive, up to $2,000 more expensive in one study with an endoscopic approach. But the differences in cost are less clear when you consider more than just the upfront cost. So this looks at cost effectiveness, which is the societal cost of carpal tunnel syndrome and its surgical treatment. So cost effectiveness also takes into account time off of work following surgery. And in one study, they assumed that patients undergoing endoscopic release would return to work 8.2 days faster than those undergoing open release. And they found that based on this and time off of work, endoscopic release was more cost effective. In another study, they evaluated workers' compensation trends. This was in Washington State. They evaluated over 5 years, and they found that there was $310 million in claims related to carpal tunnel surgery, and half of that was from temporary disability, with about an average of 30 days off of work. So that's a significant amount of money, and if you factor in the time off of work, then an endoscopic technique is certainly more cost effective. But this is a moot point in the retired population. As we looked at the age distribution, there's a fair amount of patients in their 80s that develop carpal tunnel syndrome. So you can't really argue the cost effectiveness with endoscopic techniques if patients aren't working. So, in conclusion, it's important to do a thorough history and physical. And in most cases, you can reliably diagnose carpal tunnel syndrome. And the CTS-6 score is a really valuable diagnostic tool. If you see a lot of patients that come in for numbness and tingling in their hands, that can really help you decide if you need electrodiagnostic studies or not. Surgery is indicated in patients that have severe carpal tunnel syndrome. So those are patients that have constant numbness, thenar atrophy or weakness, or electrodiagnostic studies that show they have severe findings consistent with denervation. Endoscopic technique has the benefit of faster recovery, faster return of strength, earlier return to work. However, there's also a greater risk of transient neuropraxia, so some symptom benefit may be a little delayed in those patients. Open carpal tunnel release has a higher risk of wound complications and scar problems, but most studies show that all other outcome measures are the same by 3 months after surgery. Upfront costs are much higher with endoscopic carpal tunnel release, but it's also more cost effective in the working population. And in the end, I think if endoscopic carpal tunnel release is something that you do frequently, you're cognizant and aware of the anatomy and possible anatomic variations, it is safe and patients do well and are very satisfied. However, there's plenty of concern even within the hand. The ASSH or fellowship trained hand surgeons, that there are enough significant risks with endoscopic techniques that surgeons won't do them. And so 50% of those surgeons surveyed say, I never do endoscopic release, and there's good position papers that explain why. So that's a very reasonable position to have as well. I think ultimately it comes up to surgeon preference, patient preference, an honest conversation about risks and benefits of both options. And I do both for different reasons. And I think both are very reasonable with good outcomes. That's all I have. Any questions? Yes.
Once you cut the transverse ligament, thank you. Once you cut the transverse ligament, can you get a complication of fibrous tissue causing the ligament to reform where you need a second release surgery?
It scars. Yeah, so you take this tight tunnel and you cut it, and like we saw in the picture, that you see the two leaflets, it's here, so then you've got scar that can form, and it still is a tunnel, essentially. So yes, you can have recurrence, and we do see that. Recurrence happens for various reasons, so it's important to know, did all the symptoms go away initially after surgery? Is recurrence somehow related to maybe an injury to the nerve? There's other things that can cause recurrent numbness and tingling, but yes, if it's simply just 15 years down the road, my numbness came back, then yeah, it may be because you've scarred, you still have a tight tunnel. The tendons in the tunnel can develop more tenosynovitis and other things that make the tunnel smaller for the nerve. Yeah.
Just a couple other quick questions. Is most of the time, are the symptoms in the dominant hand? And if they are, and you do the release in the dominant hand, is there a fairly significant percent of the population that will get carpal tunnel syndrome in the non-dominant hand?
I don't know that I've seen anything that shows that hand dominance plays a factor, but the same risk factors apply. So if the patient has a risk factor for developing it in the first place, it still applies to their contralateral hand. So yeah, they may develop it. Yeah. All right. Great. Well, thank you.